Okay. Thank you everyone for attending the CureGN Pathology DPR training. This training is being recorded, so if you're not speaking, please mute your phone so we can cut out the background noise. And the recording will be available on Basecamp. And if you want to ask a question, but you just don't feel comfortable speaking up, you can always use the chat function. The agenda, we're going to do a quick introduction and why of the DPR, and then we'll go through the MOP, including logistics and de-identification, and then a GN link demo and training, and then cover some next steps. And then we also have time for questions if you don't get your questions in during the training. First up, I'm going to go ahead and pass this over to Colleen, who will do the introduction.
Hello. All right. So I just wanted to give a little bit of an overview of how what we're doing now for the DPR differs from what we did pre-2021. So if you have sent in slides either this year or last year, the system hasn't changed since then. This is just if you haven't done that since 2017, 2018, 2014, here are some of the differences. So in the older system, we still collect biopsy reports, EMs, and glass slides. That hasn't changed, but we are no longer collecting IFs. So we don't need those. And the biopsy report no longer has to be sent to the DPR. It's no longer part of our storage. So we are still de-identifying materials, of course, before they go into the DPR. But rather than using the CureGN identifier, so the 3-3 number, we're using something called biopsy ID. And so this is for Cure, it's either a 2 underscore or a 3 underscore number. And this just makes it double de-identified. So the folks looking at the materials can't even tell what site things are from. And so for biopsy reports, those now use the biopsy ID instead of the like I said, the 3-3. The glass slide labels, you'll see as Melissa shows some of the slides, those look a little different than what they used to, and they look different than the biosample labels. They just have a 12-digit code on them and a barcode. The other big thing that we've changed is that the QC of the de-identification happens before things go to the DPR. So again, previously de-identification happened, things were put on a CD and sent in, and then if there were issues, things would have to be updated, put on a new CD and sent in. So now we're catching all of, just any issues ahead of time. So you will still link the glass slide barcodes, so those labels, you'll still link them to the participant in GNLink, very similar to how you used to and very similar to how you do for biosamples. They still get shipped in the system where you push a button and an email goes, and they still get physically sent somewhere for scanning. Again, what's different is we're not using those CDs. So the EMs just get uploaded into GNLink. And Melissa will show that, but that's much simpler. We have provided some cork-lined slide boxes for shipping. Our scanning facility, MHL, they recommended these to just help with any potential breakage. The other thing that's a bit different is that in like 2018, we were very restrictive about who could send slides when. And even the last couple rounds, we've had to be. This round, our goal is 2,000 slides, approximately 200 patients, and we're really just opening it up to all sites so we can get as many of those in as quickly as possible. Last item here, not as relevant for some of you, but the pathologists are using different software. It's called HaloLink, and so sometimes you'll hear us talk about things being in HaloLink, and that just means that the materials are available for core scorers or for other investigators who are doing, or researchers who are doing work. So, all right, I think my next slide is just a workflow diagram. going from sort of the bottom left there with the pathology departments having the materials to you all. So for the collection, the de-identification, and then the electronic transfer there going up, the reports and the EMs. And a new thing that's part of the QC process, it's a scan of the glass slides. So again, Melissa's going to explain it to you, but once you have those labels done on the slides, you're going to flip them over and put them on a copy machine and create a scan of the image. And that image gets uploaded, and that's part of our QC, is that Jess will pull it up and look at it, and then I'll give you feedback. Like, oh, don't include this one. Oh, wait, this one's crooked. Or, oh, wait, I can still see, something through the label. You'll get all that feedback before you're allowed to actually ship the slides. So again, we're doing as much of the QC, pushing it as early as possible because it does actually save time. So that electronically, part of the DCC will do that QC, and then the EMs, and actually that scan of the glass slides, it should be going along the top there. They get synced automatically to a server that's at NIDDK. And so again, another reason why we're doing all that QC, getting all this PHI out of everything, is they don't want it on their server, right? Rightfully so. So we're trying to catch everything before that happens. Along the bottom there, you'll see once the scan of the glass images, once that's been QC'd and just pushes a button, you'll then be able, in the system, you'll see a button that actually will let you ship. And so it'll let you ship in the system, and you can include your manifest in your box and send your box on to MHL. When they are done with the scanning, the images go into the DPR and are available in Halo Link. Then there's an arrow missing, which is that the slides do come back to you then. So, all right. I think maybe, are those my only, do I have anything else, Melissa?
Yep, those are your 2 slides.
All right, awesome.
Thank you. Okay, so now we're going to talk about the why of the DPR, and I will pass this on to Laura Barasoni.
So, hi everybody. Why do we have the digital pathology repository? Reason number one is the new standard. It's the new state of the art, and we started many years ago when CureGN was the second, after Neptune, the second digital pathology repository. But after that, this is every single consortium is built in digital pathology repository. Why do we want to have that? Because in the past, if you think about, we will have to have local pathologists review their slides and tell us what it was. Nobody could really QC. It was just the opinion of one pathologist. Or the slides would have to travel from one place to another pathologist, to another pathologist, to another. Imagine that, right? And now the slides have to travel once, they scan, and now we have a permanent digital library of images that can be looked at by anybody, anywhere, at any time. And this is a very powerful tool. Why do we want to, why pathology is important? Because in reality, we don't know much about it yet. And the way we have been doing pathology using conventional diagnosis really doesn't explain the biology behind the diseases and how the structural changes happen in the kidney. This is an example. For example, this lesion that you see here is a lesion of focal segmental glomerulosclerosis. But itself doesn't say anything. In fact, this can be present in patient A as well as in patient B. It can be exactly the same. One is a man, one is a woman, different race, different clinical history, and different outcome. One is going in dialysis, the other one is responding to therapy. So the idea is that if we have a permanent library of images, we can do more than conventional diagnosis, and we can explore different methodology and interrogate the tissue so that we can extract information that were not available to us before. Next one. So what do we know or what we don't know? Well, the biopsy is still very important because it's still the standard of care especially for adults, and it's used to define glomerular lesions and assign a diagnosis, and we still need that. However, the kidney contains additional information about etiology and prognosis that go beyond those that we use for diagnostic approaches. And so there are a set of structures. For example, we are studying CureGN, is glomerular disease, right? And so everybody focuses on the glomerulus, but in reality, the glomerulus is just not floating in the air. It's floating into tubules and interstitium, and they can be inflamed and they can be scarred. So all these components are important. And so we should, the DPR allows us to place ourselves in a position where we can actually study all these elements. When we study this element using visual assessment, there is a certain lack of standardization or the lack of reproducibility because visual assessment is subjective. And pathologists are really good in interpreting data, but in reality, they're not good in quantifying data because, again, it's difficult to count. It's difficult to measure the size of things with the human eye, right? So the all slide images that are the digital class slides and artificial intelligence and machine learning offer an unprecedented opportunity to improve the way we do pathology. Next. So what is digital pathology? For those that are totally new to CureGN, we take the class slides, we scan them into all slide images, we upload them into a servers, and now everybody can have access to the same image. And we can simultaneously or over time do different things. We can apply human visual assessment using conventional methodologies, conventional diagnostic criteria, or even come up with new methodologies. But we can also use computer vision for automatic detection, segmentation, so basically defining the boundaries of the object. We can quantify the object in a way the pathologist can't. We cannot count cells. We barely reproducible actually in counting glomeruli, not even that. We can use it to classify things and to predict the outcome of disease. Next. So DPR and visual assessment, how has it been used? This is just an example from Neptune, has been published some time ago. In Neptune, what we did, we scan all the slides and we visualize them. And can I have control over the screen, Melissa? Is it possible?
Yeah, give me just 1 second here.
I think would be easy. Take control. There it is. I found it.
Did you get it?
Yeah.
Oh, yeah. I just need to allow you. Hang on.
Okay, now you can see. So we can visualize up to 4 sections. We enumerated the glomeruli, and we score the glomeruli across all the levels. This is very important because we can capture all the elements that or the changes that appear across all the levels of the biopsy. And then we score these glomeruli for a variety of parameters. We score them for two interstitial damage and electron microscopy damage. And when we did an unsupervised cluster analysis, so instead of using the conventional classification system like FSGS, minima changes, IgA, etc. This is a study that was done on minima changes in FSGS. We used all these elements and did unsupervised clustering to identify group of patients that have similarities. And so we found 3 groups of patients, cluster X, Y, and Z. And each of these clusters are populated by FSGS as well as minimal change disease in a different proportion, but they are. And then we look at which of these parameters actually drive cluster membership, right? Which are the important parameters? And as you see here, for example, number 1 is the absence of any change. That is actually very relevant. But also the presence of global sclerosis is very relevant, or the presence of podocyte injury or endothelial cell injury. Ironically, food process effacement, which people think is the most important thing to know in nephrotic syndrome, was not among these top parameters. And so we were able to not only classify patients in a different way, right, from what we do, but also to identify parameters that usually we don't use. And these clusters turn out to be clinically relevant. Can I move to the next one? It doesn't progress when okay, there it is. These clusters turn out to be clinically relevant. So cluster X was the one with the worst outcome compared to cluster Y and Z. And when we compared those to conventional classification system, there was only a partial overlap. So we were able to do some discovery using the digital pathology repository. And the clusters also were biologically relevant. So each cluster was associated with activation or inhibition of molecular pathways. So it gives us the opportunity to look at how the structure is linked to molecular, and so how we can target better. It gave us the opportunity to think how we can better target the disease, but not the disease FSGS, because we know FSGS is very heterogeneous, but a specific pattern which could be present in FSGS as well as in minimal change disease. Next, oh, too far. Now, digital pathology and computer vision. What is computer vision? It's artificial intelligence. So we built a model for the automatic detection and segmentation, basically identification of the boundaries of the functional tissue units. What are the functional tissue units? They are glomeruli, the tubules, the peritubular capillaries, the capillaries around the tubules, the arteries, and so on. That can be done using healthy tissue and also in glomerular disease. This is an example of minimal change disease. So we're able to automatically segment using all the staining, peritubular capillary, glomerular unit, so the Bowman's cups or glomerular tuft, proximal, distal tubules, and so on. So then, once we have this, we can really start extracting information that we never had before. And those are called pathomic features or subvisual features. So these are features that the human eye cannot, characteristic of the tissue that the human eye cannot capture. And here are 3 examples. There is something that is covering. Do you see this covering my image? Yeah, okay. So this is an example. We use cases of FSGS and minimal change disease, and we extracted these features. And so here you have the non-globally sclerotic glomeruli, the segmental sclerotic glomeruli, and the globally sclerotic glomeruli in 3 different colors, right? But we use only the non-sclerotic glomeruli, and we extracted features from glomeruli that look normal in FSGS and minimal change disease. And we found that we use the top most predictive features of outcome. And we compare how these features predict outcome compared to conventional approaches. And we saw that actually the 10 top glomerular features are more predictive of outcome of disease progression compared to any approach that we use normally. And those, think about it, right? There is some visual features extracted from normal glomeruli. We did the same experiment using the tubules. We extracted 56 different pathomic features. For the glomeruli, we extracted 203 characteristics. Imagine that, right? So for the tubule, we extracted 56 characteristics, and we identified the top 10 that are most predictive of outcome. And again, we compare how the prognostic accuracy of these characteristics, pathomic features, compared to conventional diagnostic features. And again, for disease progression, the pathomic features, a visual feature, were superior compared to conventional approaches to predict outcome. And the last, we look at characteristic. Can you do a click? It didn't click for me. We look at characteristic of peritubular capillaries. Those are more small vessels in between the tubules that we can see, but we definitely cannot count. We cannot measure. But with these approaches, we measure the aspect ratio, how flat they are, how round they are. We just gave numbers. They're not just that flat or round. You just gave number to every single one. 2,000-3,000 peritubular capillaries per biopsy were measured. The density, the size, and we found that, for example, the aspect ratio, so how they're flat, the more they're flat, the worse the outcome is for the patient. So novel information that we never had before. Next. And once we have all this information, we can link those to clinical data and omic data and really identify more clinically relevant and biologically relevant disease categories. So ultimately, that should help us to improve the clinical outcome prediction, but also how we can identify new therapeutic targets. Next one. More logistic, Melissa.
Thank you, Laura. Okay. So the materials associated with the kidney biopsy retrieval, de-identification, and shipping protocol. The items that have been provided by the DCC to your sites are the training materials, the GN barcode labels, cork-lined slide boxes for shipping slides to and from the scanning facility, as well as a thin piece of padding for inside the glass slide container, and then access to GN Link. Here's an example of what the barcodes look like now on the labels. They start with an 11, and then it's just a whole bunch of zeros and then the number of the label. There's no site identification on them. And there's a place for you to put the level and a space for the stain. The items provided by the CureGN site or your PCC are all the pathology materials for the enrolled participant, a thin and wide Sharpie, or a permanent marking pen. So when you're writing on the labels, and then the wide one is for de-identifying any hard copies of the path reports. The padded envelope for mailing, we do actually, from the DCC, we supplied you with some. If you've used those, then you can use, just get other padded envelopes for mailing. And then it is suggested that you use lab tape for the cork-lined slide boxes instead of just regular tape, which sticks, leaves a residue on the boxes. So MHL has requested that we use the lab tape instead. This is just a new diagram that was created and is included in the new MOP. It's just a pathology workflow, starting from enrolling the participants and all the way down to receiving the slides back. So what needs to be collected in QC? The pathology report. You want to de-identify and label it with the biopsy ID, as well as X of Y on every page, where X is the page number and Y is the total number of pages. You'll upload that to Link, and then it'll be QC'd by Jess here at the DCC. You will be notified once that is approved and passed QC, and then it goes to the pathologist for your site to go ahead and do the pathology CRF. And then we've got EM images are de-identified and labeled with the biopsy ID and X of Y on each image, where X is the image number and Y is the total number of images. Those as well get uploaded into Link, but they do need to be in JPEG format. And then those images are, again, QC'd by Jess, and then they get transferred over to the DPR. And you will be notified that they've passed QC, so you're not left wondering. The glass slides are labeled with a study label, and then you want to handwrite on there the level and the stain. The glass slide image is created, as Colleen had spoken of, where you're just going to take the slides, put them upside down on the copier so you can make a copy, scan side of it. And we do ask that you do that in color. And then the slide copy is then uploaded in the JPEG form into Link. And the image is, again, QC'd by the DCC before the slides can be shipped, okay? But we will let you know as soon as they pass QC so that you can get them shipped. And we do suggest that you just do, in the beginning, you do one case, you de-identify it, and then upload it into Link. That way, if there is any major issues, you're only doing one case that you have to redo, and then it'll help you do the rest of your cases. So we don't want you to do all your cases at once. And that goes with the EM images and the pathology report too. You know, do one, upload it. Once it passed QC, you know that you've done it correctly, and then you can go ahead and do the rest of them. We find that that does save time for sites. And then we have the whole glass slide images, which are reviewed in Halo Link and then made available to other users. So the central QC for the de-identified glass slides, EM, and pathology reports, it all happens virtually. The de-identified pathology report is uploaded to Link as well as the EM images. And then the glass slides, it's the scanned image that's uploaded. And as a reminder, the EM and the glass slides have to be in JPEG form. And the copies should be done in color. De-identification, I will pass this back to Laura.
All right. So the identification is the most painful part. So what do we de-identify? We de-identify the pathology report, whether it's PDF preferably or the hard copy, and we'll see how. The EM images and the glass slides. Which ones? All histology slides. Those are the formalin fixed and paraffin embedded tissue sections, the ones that we use for light microscopy. They generally are from 4 to 9. Now, 4 is really not an enough number. We really want to have 8, 9 slides. So if they give you 4 only, complain, see if we can get more. And they generally look the same. The tissue looks the same, and they have different colors, but it looks the same. Then the glass slides from the frozen section of the tissue that is embedded in OCT and is used for immunofluorescence, but they always take a section they stain it with H&E. We want that too. That generates a smaller fragment of tissue. So you will see that it looks different compared to the others. And then the glass slides with the thick section that is stained with toluidine blue is generally blue, small fragment of tissue, different from all the others, very small, generally more than one section per slide. And that's a tissue that is used for electron microscopy. But again, the pathologists take a section, they look at under light microscopy, they decide it's good tissue, and then they do electron microscopy. So all this material needs to be de-identified. Next. Pathology report. So pathology report, how does it look like? So the pathology report can trick you in so many ways, but let's see how we can trick the pathology report back. So number one, you will have several sections. The top section is the section that contains the institution information, the logo, the name, the address, telephone number, sometimes the name of the pathologist. And this is always at the top. And in this section, there is nothing that you need. So this section has to go. Don't even bother reading it. You know what it is. just goes. Underneath that, there is a patient specimen identifier. So here you have all the information about the patient. So this section has to go entirely because it has the name, the date of birth, the date of the biopsy, specimen identifier, the bed number, who requested, who is the pathologist, the QR code that can identify everything. There is nothing here that you need except for the age of the patient. That's the only thing that you want to write down somewhere. Everything else, you don't need it. Don't even bother reading it because you don't need it. Just find the age of the patient or calculate the age of the patient from the date of birth, but and write it down. Then the sorry, go next. All right. Now, part C, underneath that. No, let's do DAE first. Then you go to the bottom, the E. E generally is the footer, generally has the specimen identifier patient's name. I'm talking about the majority of report. Some will look different, and the information will be distributed differently. But as long as you know what the informations are, you should be able to find them and delete them. So E obviously has to go. Don't even bother, cut it down, cut it out. And if you know this, instead of trying to mark out or to delete individual name and information, you just take the whole section out. It moves a lot faster. Then there is always at the bottom the clear language or other disclaimer. This is just part of the laboratory language. Here you will have information embedded in this paragraph that really identify the institution. So there is nothing here that you need. The only part that you need of this report is part C. That's the central part, has the diagnosis, the comment, the gross description, microscopic, immunofluorescent, and electron microscopy. You should have all these sections. If you're missing one, your report may be incomplete. So look, all these sections should be there. It's pretty standard. Unless no electron microscopy was done, but should be indicated. So obviously diagnosis test. Under the diagnosis, you will always have the name of the pathologist. So remember, when you look at any report, any name, any sequence of numbers, or any date should go. There is no reason for keeping any of these three information, names, dates, and sequence of number in any section of the report. Next. Well, except for creatinine was 3.1. That's, I mean, things, things like that. So from the top, delete any reference to in the institution where the biopsy is performed or processed or interpreted. The institution's name can appear in many places, in the gross description, in the clinical information, in the comments section, in the patient identifier section, just has to go. Logo goes. Name, address, fax number, everything. You can find them in multiple places, at the top section, in the gross description, the footer, in the electron microscopy, they all have to go. Clear numbers, specific other things that are relevant that can identify the institution have to go. The disclaimer, the QR code. Next. So, and I cannot say this enough. Delete any name or initial of any individual. The patient name. And these are the sections where it can be found. You can find it in the identifier section, be in the footer, in the comment, in the clinical information, the gross description. It tricks you, can appear in many places. Any patient identifier, the date of birth, race, medical record number, and so again, you can find them in many places. Also, delete any name of pathologists or physicians that appear. And any personal name goes, doesn't matter who they are. The group of pathologists belonging to a practice or other physicians. For example, in the comment, you may see the case was discussed with Dr. X and Y, right? if you leave that, I know, or the case was discussed with Dr. Appel. If you leave that, I know this is a Columbia case. So, next. Other things to be deleted, any date that refers to the biopsy or any other specimen identifiers. And you can find them in multiple places. And I will show you some examples. We're going through the examples, right? So, what should not appear in the report after the identification? Any name, any date, any series of letter numbers, except for the MES score, except for creatinine was 3.1. Any identifier of any location. Date of birth should remove, age should stay. Next. Example. So, section A, institution. There's nothing here you need. All go, delete. Section B, patients and biopsy identifiers. Everything here is just a disaster, should not stay, except for the age. So everything else goes. This is the specimen identifier. This is obviously the QR code. Here you have other identifier, and here you have the assigned pathologist who ordered the biopsy, when was collected, when was received. We don't want to know any of this. Clear. In yellow, you see how yeah, here sometimes you can have the clear number. So, but there is nothing here that is really relevant. It's just a disclaimer of the laboratory. So delete all this section. Okay, headers and footers. Again, you will have in the corner the specimen and the patient name. They have to go. But also look in the text, because you may find this information embedded in the text in part C, and that is where it can trick you. Go ahead, next. Section C, diagnosis. Okay, diagnosis obviously stay, but under the diagnosis, somebody says, I have reviewed the biopsy, and this is the doctor, and this is the resident. Delete that part. Section C, yes. The name goes, race goes, the case was discussed with Dr. X and Y on that date, because everything can really bring you back. And the case was also reviewed in consultation with Dr. such and such. I'll go. Clinical information. Clinical information has a lot of information that we don't want. And so, as you see here, you can refer to he was in a different hospital before, and there was a biopsy in that year, and then even with the biopsy number, and then he moved to North Carolina. It's like, no, because people can't figure out who the patient is. So all goes. Cross description. Cross description may contain information. Very often, like we receive 3 bio label with the patient's name, Joe Smith, and another hospital number, and it was a session here with this number. Has to go. So you have to read through section C very carefully. The light microscopy and microscopic description generally doesn't have any identifier. So immunofluorescence, those are safe places. But the electron microscopy may, because it may have another number attached to it, and it may have the technician initial, so the person who review it. In some cases they do. So read that section more carefully. Next. Pathology report, we need to de-identify. So we have 3 options. We have a PDF, we have a Microsoft document, or we have a hard copy. So try to avoid the hard copy. If you have the hard copy, you take a marker and you go over everything, and then you scan it. Better, easy to work with the PDF or Microsoft document. Before you do anything, save a copy on your computer as save as patient initials _ path _ report. After you save it, then you open the document again. Open a blank Microsoft Office documents or similar text editing software. And select all, copy, and return cursor to the text editing software blank Word document. Paste and save these as a new document. And for the Microsoft document redaction, first save the document on your computer with the patient's initial as well. Next one. And you do the same thing with the hard copy. So you scan it as it is and you save with the patient initial, and then you redact it. So if you have an electronic copy, a PDF, the pathology report, go into the tools, the PDF, choose the redact icon, and start redacting using that. So select the text to redact, click mark for redaction from the redact ribbon, click text and image, select text or image to be redacted, click or apply from the redact ribbon, click on OK and yes. When the pop-up come up, when you're done, you save as, always save as redacted, and you now add the CureGN biopsy ID _ path _ report. So now you will have in your file the document pre-de-identification that is saved as patient's initial, and now the identified document that is saved with the biopsy ID. And the reason why we want you to keep both, because if there is a mix-up somewhere, sometimes you wrote the wrong number, etc., we can always go back to the original, just comparing the reports. Next, if you have a Microsoft Office document, you open it, you open the one labeled patient initial and so on, and you start the identification. You use the backspace or delete key to do that. You select the text that you want to de-identify. The best way, instead of leaving blank, because sometimes it just doesn't make any sense, put XXX or put deleted text. So you know that you deleted portion of, people who read that know that you deleted portion of text there. And then again, save as CureGN biopsy ID _ path _ report. And again, you should have in your computer one copy that has patient's initials and is not redacted, and one copy that has biopsy ID that is redacted. Same reason, if something happens, we have a mix-up, we can always go back. Next. The hard copy, scan it, save it with CureGN patient's initial, and then mark. So delete with a black marker, rescan it, and save it with CureGN biopsy ID. So each, no matter what you do, you should always end up with 2 copies. Next. I said that. EM image de-identification. So what to delete? So we delete the same thing. Anything that has name, dates, refers to the patients, and so on. The only thing that is really important to maintain in the EM is the magnification and the scale that you see here. Everything else is really not important. So the EM will have dates, we have patients identifier, we have pathologist identifier, operators identifier, etc. Go on. Thanks. So you open the digital EM image with Paint. This is the best way to do it. And if you have another form, just open it with Paint. Open that and save it with Paint. Just try to go to Paint. On the top, there's a top bar with the tool. Click 2D shape, and then the 2D shape will appear. The option will appear on the right side, and you want to select the square rectangular. Next, and then you drag the rectangular on top of the areas that you want to mask, and you do that for for everything you want to mask. Can be just everything can be all in one place, so it's easy, or it can be in different places, so you have to drag more than one square. What is very important, next. So now you mask everything that you need to mask. Now you have to relabel the image, each image. So you go again up on the top, you select text, and you type the biopsy ID _EM _ depending on how many images you have. So if you have 4 images in total, _1 of 4, and then you go to the next image and you label that 2 of 4. And so each image has to have a unique identifier, which is the biopsy ID _EM, and how many, which this is image number 1 of a total of 4. This is image number 2 of a total of 4. Again, the reason why we do that, because EM images look the same, numbers look very similar. If things can get lost in cyberspace, if you tell me, if you tell me that there are 1 of 4, or 1 of 10, 2 of 10, 3 of 10, but at the end I receive only 9 images, I know that one image has been misplaced, maybe ended up with another patient, and so it's easier to avoid mix-up. So that's why it's very important. And so you select it. Now, you de-identify, you re-identify the image. Now you have to save as. Why do we want to save as, not just save it? If you save it as it is, you say, I'm saving it. And then you go into the file and click rename, right? You rename it. You rename it with the biopsy ID 123 _321 _EM _1 of 4. Because each image has to have a unique identifier, 2 of 4, 3 of 4. And now you send it to me. I can click on your bars that your square, and I can unmask the identifiers. Because you haven't, they're there. I don't see it, but if I click on it, I can unmask it. But if you do save as, nobody can go back to those, because now they're permanently deleted from your image. Next. Oh, the white space part. I hate that.
So no, that's okay. So if there's no white space at the bottom of your EM image for you to relabel it, you need to add it, because you do not want to put anything over the actual image. So it's best to just open the EM image just as a JPEG, and then using your snipping tool, go ahead and select the image. You just want to make sure that you have like a little border around it, just so that you know that you haven't cut anything out of the image. And then you're going to open the Paint program and just paste that image in. And then what you're going to see is if you click on the white spaces around the image that you've pasted, there's the little handles. And so you just want to go ahead and pull it down at the bottom so you have the white space. If you have white space on the side, you can just pull it in so you can get rid of that. Okay. And then once you've done that, you can do the text icon and label it at the bottom. This image here also shows the file name So the file name should match what you've listed down here as well. Okay. And again, make sure that you save as a JPEG, and then you upload the image to GNLink.
Perfect. Am I doing the glass slides? Glass slides. So what are the glass slides that we want and which one we don't want? So formalin fixed paraffin embedded tissue is the one that generates tissue section for the light microscopy. They're staying with H&E, PIS, trichrome, silver, sometimes other things, but this is like the basic that we really want. And generally, there is more than one H&E, more than one PIS. There's times also more than one trichrome and silver gel. We want those. We also want, as I said, the EM glass slides staying with totally blue. Those are a small piece of tissue. They look blue, and they have a small cover slip. You can see that. And then the frozen section from staying with the H&E from the tissue that is used for immunofluorescence. What we do not want is the sections that are staying for immunofluorescence, because those are staying with antibodies against IgG, IgA, IgM, and they will be labeled as such. And we can't see them because you can see them only on the immunofluorescence. So if you think about the scanner can scan tissue that can see, not scan tissue that cannot see, that you hold up the glass slides and you don't see anything. So you don't want any glass slides that look empty. You also do not want control. So if for histology of any other, for that matter, sometimes they put a control slide that looks actually like a kidney and is a PIS or something else. That is a big piece of tissue. You don't want that. If the big piece of tissue is on the same slide as the biopsy, you have no choice to keep it. But if it's on a different slide, we don't want it. Think about that. We spend money for each of the slides that we scan, so we don't want the ones that we cannot scan. Let's look at some example. Okay. Also, if the slides are broken, don't send it to us because we cannot scan them. Next. So de-identification. You will have received the printed labels from the CureGN pathology kit. It has a barcode on top and then an area here where to put the level. What is the level? Again, if you have the paraffin block, you cut multiple level in the block. You stay H&E, PIS, trichrome silver, H&E, PIS, trichrome silver. You want to label level 1, level 2, level 5. Very often, they're not sequential number because pathologists want to stay in 2 levels and then skip 3 and then stay in another 2 and skip 3. So don't worry if they're not sequential. Actually, it's better if they're not. You will find the level written on the label of your glass slides and ask your pathologist to show where it is. What do we have on the original label? You will have maybe a barcode, or maybe not, but people are moving to barcodes, patient's name, surgical pathology number, and then you will have the stain, and you will have the block, which is generally A or A1, and then the level, 1, 2, 3, 4, 5. So you have all this information. Each place is a little bit different. So the best thing is to go to your pathologist and ask them, show me what the block indicator is, what the level indicator is, where do I find the stain? That's all you need to know. And the patient's name, because you need to match it. Okay. But then here, you want to mark the level indicator, level 1, 2, 3, 4, 5. And here up here, you want to indicate the stain. That will be the best thing that you can do for the DPR. Sometimes you don't find the level. Sometimes I understand it's difficult. Next. So, as I said, glass slides from EM do not have level. They also look different. So you can see here that all these slides look the same. So you know they belong to the same biopsy. And the frozen section is much smaller. It looks different. This is how they look like when you receive them. This is how you label them. And you should put the level here and the stain over here. Before applying the barcode, make sure that you know which level it is. Next, also make sure that when you apply the barcode, you apply it in a way that you really mask everything. So we want to know the stain. We want to have glass that are in good condition, no bubbles, no cracks, excessive folding of the tissue. If you can see that the tissue is all, probably that's not a good slide. They need to be labeled correctly. No identifier should be visible. That should be labeled with level and stain time. For example, let's look at this one. The first one. The first one is good. Has a trichrome, and then A is the block, and 1 is the level. So tissue looks good, no bubble. Look at 2 and 3. They, first of all, there are multiple things that are wrong. Number one, you cannot see the tissue. When you see this thing around it, this pen mark, it means that this is a immunofluorescence section. And also, because it says IF negative, it also says fibrinogen. All right, fibrinogen is the type of stain for immunofluorescence. For some reason, this is also super bad because it also says trichrome, which makes no sense so that can trick you. But the fact that you have fibrinogen, the fact that you have this round circle, and that you cannot see the section, this is a slide that we want. EM A2. Sometimes EM has level. Most of the time they don't, but sometimes they do. Here you have a small tissue set. Here you have a square, small cover slip. But I see no problem with this tissue, so that's good. So this is a question mark. So the tissue is good. The stain is there, but it's missing the level. So that maybe you can find the level, but that is partially complete, right? This is the good section. You have the tissue, you have the block, the level, you have the stain. This is not good. It's cracked. We don't want it. This one has the same issues as this one over here. We don't want it. And this is good. It's H&E, blockade, level 5, done. Sometimes the block will be A1 dash 5. 5 is a level. Sometimes the block would just be A. You really need to know what is the practice in your hospital. Label, another issue with label. Sometimes glass slides go somewhere else for second opinion. So what pathologists do, they put a second label here that belongs to the hospital with the second opinion, with the patient's identifier. So you have patient's identifier on top, patient identifier on the bottom. Sometimes they put it in the back. So you have patient identifier here and in the back. What you should do is you cover this with the CureGN label, and then you use a blank label from the bottom if it's the bottom, or a blank label on the back if it's in the back. If the label is put in the back, though, now you have a different issue, because now you have a label and then you put a blank label on it. Now you have 2 labels. Now your glass slide is no longer flat when you put it in the scanner, but it's a little bit tilted, right? The scanner looks at has to focus. So when you focus here, it's not focusing here because now your slide is like that. So if you have 2 labels in the back, you should put 2 small labels at the bottom here, one on top of the other, in a way that don't cover the tissue, so that your section is still flat. And now you can scan one. Next. Now, Melissa, is you.
Yes, thank you, Laura. So preparing your slides for shipping. You want to use a manifest when you have all your slides ready to go. For this step, you can use a PDF version, or you can wait and use the CSV version. You want to make sure that the slides are placed in the cork line boxes in the order that they are on the manifest. So they generally will be in the order of by participant and then in sequential order. If you're using more than one box, make sure to indicate on the boxes the order they should be opened according to the manifest. So do like 1 of 3, 2 of 3, 3 of 3. Place the layer of padding on the top of the slides and close the box, and just give it a very light shake, just to ensure that there's no slide movement. If you hear any movement, please add a little bit more padding until you don't hear any movement. This is going to help ensure the safety shipment of the slides. Then you can place a rubber band around the box, both vertically and horizontally, just to kind of help keep it closed, and use a piece of lab tape on either side of the clasp. This just kind of helps ensure that the box does not open during shipment. And then you want to place the boxes in a padded FedEx envelope along with a copy of the manifest, either PDF or CSV version. Again, at this stage, either one is fine. And then do not close the envelope yet. So shipping, when you're using, or you want to use the DPR MOP Appendix D, which talks about shipping with FedEx, because you're going to need to create a shipping label and a return shipping label. If you don't put in the return shipping label, that can open up the possibility of errors being done when they're shipped back, like being shipped to the wrong site or something like that. So you have to put in that return label. Once you've printed that in, make sure you use the instructions, because it gives you the account code in which to charge the shipment to. And then you place the return label in the padded envelope along with the slides and the manifest. And then you place the shipping label in a plastic sleeve and attach it to the outside of the envelope and seal the envelope at that point. And then just schedule a pickup or drop off at a specified shipping location, whatever your institution policy is. One other thing, and we cover this later, but when you're putting the return shipping label along with the slides and the manifest inside the envelope, if you are shipping from international, so if you're shipping from Italy, Warsaw, or from Canada, please, if there's any additional stickers that need to go on the box when they ship it back to you, please include those in the envelope for them. That way you know the right thing is done and it doesn't get stuck in customs, because it can take a while to get them out. We've had to do that already. So this big tip, make sure you put anything that's going to need to be on the envelope there. So when you receive the sites back, you do need to enter into GN Link that you did complete them in. So you'll have to log into Link and then mark the slides as returned and indicate the condition received. And we'll show you that in a little bit. Right now. Any questions so far? I see that there was a question in the chat and Jess did respond to it, but just in case anyone didn't see it, in the narrative of the report, we should also redact any reference to the patient's gender, correct? And yes, that is correct. You want to remove all references to patient gender, including pronouns.
Melissa, I'm just going to put a plug in for some of what you're about to show, which is MHLs, our scanning group. They're very good about the 2-week turnaround. So there is a 2-week turnaround between when you get the slides out the door and when you get them back. When they have failed that, it has always been 2 things. One, there's a problem with the manifest. So the manifest you email them does not in some way match the material they receive. And we've had both, there are more slides in the box than on the manifest, and there are less slides in the box. So if you're worried about get how long your slides will be out of your facility. Just really work on getting only the slides in the box that are also in the manifest. The second thing that's tripped them up is not having return labels. So again, and the good thing is that both of those things are, under your control. So I'm putting in a plug for everything Melissa's about to tell you, because again, that's where MHL has tripped up. So, okay, thanks, Melissa.
Thanks, Colleen. So yeah, these are a lot of these that we're really stressing. It's lessons learned from the previous round that we did. So please take it as good advice. Okay, so when you first go in, when you enroll a participant is when you put in the pathology report upload. It's under the enrollment. When you go in, this is where you can find the biopsy ID up here in the upper left corner. You want to just go in and upload files, add files. You want to select it. I don't have anything to select right now. And then you just upload all. Okay, so that doesn't change at all. It's the same as what you've been doing. And then if we go back to, let me do it this way to make it easier. Questionnaire complete. Always want to make sure you do that one as well. And then you're going to have the enrolling biopsy material. Now, when you first do this, you're just going to have the pathology slide collection and the EM image upload. So the EM image upload, same as the pathology report, you've got the biopsy ID. If you were able to obtain the EMs, put yes. If not, make sure you mark no, because that tells us that not to expect the EM images. So when you do have them and you mark yes, you do the same thing. You upload files, select your file, upload all. Okay. And then, once again, you always want to go in and complete. Okay. And then you're going to go into the pathology slide collection. Okay. And again, you still see the biopsy ID. So you get very many chances to catch it. Were pathology materials obtained? Yes. If you're not able to get the slides, go ahead and again, mark it as no. If they're just, there's not enough slides, or, there's only like 2 slides, we don't want you to go through all this trouble for 2 slides. As Laura had said, 4 is the minimum that we prefer.
We also had, unfortunately, a few cases where the pathology departments could not find the slides. So yeah, that's also a good use of the no.
Yes, correct.
Unfortunately.
Yeah. So then you want to go ahead and mark it as yes, and then the slides from enrollment biopsy date. So you want to note the date that the biopsy was done, not the date that you're uploading them or you receive them. It's the date that the biopsy was done. And then you want to go ahead and put in your starting barcode number and the ending barcode number. Same as last time. It'll be sequential. As you see here, we put in a range of 3. Again, definitely suggest and recommend strongly that you scan the labels in, the first label and the last label. It just helps you with avoiding any typos, which I know we all do. So once you do that and you generate the barcodes, you'll see them all listed here. You'll need to go in and mark the stain type from the drop down. And then if you do other stain, wrong one, other specify, then you'll have this where you can actually type in. Okay. And then you'll mark it as collected. So say you do all this, you mark everything as collected, it goes to QC, and it comes back and says, wait, you don't want to send this one in, and it's in the middle. So say this person, we were told we didn't want to send this one in. You can come back in here and just mark it as not collected. Okay, that's really the only reason why you would need to use the not collected or discarded in the facility on this is if QC came back and it's like, oh, no, that's not one of the ones we want. Do not send that slide. Okay, you hit continue. And then biosample collection complete. Okay, and at this point, you want to go ahead. You're not able to send to shipping yet or even unlink barcodes. So what you want to do is go back to continue. Takes you back into here. Once you've done that, it's going to send everything to the DCC for our QC process. Goodness. So I can just show you real quick. So it'll actually show up on here under the DCCR tab. And this is where Jess goes in and she looks at everything and QCs it. So you can see some are DC sign off. Okay, so those are all here. This is the one. Like copy QC. That's not the one we want. Okay, so anyways, it will take us to that. Okay, so let me go back into my test site. Okay. And so then we want to go back into the person here. The name key so I can see which, or password used to be called the name key for those that were in CureGN 1. Okay, this person here. All right, so when you go back in, once the QC is past QC, then you're going to have the CureGN slide copy. Load. Wait a minute, sorry. You need to do this in order for us to QC it. Oh, I'm sorry, I did misspeak. Let me go back and. So you'll have the pathology slide collection. Once you enter this information, then the CureGN slide copy upload comes in. Mark that you did obtain slides. Go ahead and upload the file where you've copied them upside down on a printer in color. You'll upload that same way as you upload the pathology report and the EM images. And then this is when it goes to the QC. Sorry about that. And that's when Jess will look at them and say if they're good. And so you're not able to complete questionnaire yet. Once it passes QC, then you come back in here and you will send to shipping. And it'll be, once it's past QC, then you're able to send it to shipping. Okay. I'm not able to pass it in QC. That's why it's not letting me do it yet. Okay. Then once you have all your slides, they've all passed QC and they're ready to be shipped. You want to come into your facility tasks and you want the shipping scanning facility. Okay. And just like you do with biosamples, click on the manifest. It does show you the address there. You always want to make sure that's correct. And then you'll select all of the samples that you're going to ship, all the labels or slides, sorry. Enter your carrier information, tracking number, date of shipment, and everything. Okay. Then you'll come to the next page. And as we all know, it takes a little bit longer when you're doing the samples. This is saying that no samples were selected for shipping because they were selected earlier. This will do the same thing, though, that you get for your biosamples where it breaks down how many of each type. This will do the same. So this is a good opportunity for you to make sure that the number of slides that you have in the box match the number of slides on the manifest. Now, you can go ahead and print at this point. You can print all pages, and this will give you the PDF of the manifest. Again, you can use this PDF to put it into the packaging in the envelope with the slides and to help you put everything in order. And it's taken a while, so we'll close that. So using a PDF at this point is fine. Then you want to do the complete and email manifest. And just like with the other biosamples, the pop-up's going to come up. It takes a little bit for it to come up, a couple seconds. Usually not more than 20. Okay. And you'll see the CSV file is included here. This is what has to go to the repository, to the CSV file, to MHL. You do not want to email them the PDF. So all you have to do is just, complete and email the manifest and hit send. It should have the NIH emails up here for the MHL, as well as Colleen's. And yours should be listed in here under the CC. If not, you can always just go ahead and enter your information. Okay. And then you hit send, and this will send the email along with the CSV file to MHL and everyone else that's listed on this email. Okay. Then MHL will receive the slides. Then they will actually receive them in link 2. They'll scan them, and then they will come back in and mark them as being shipped back. Okay. And I don't have that on here, but I will go into a site and just show you guys, since you can't see anything because everything's de-identified. Do complete. And you want to do its receiving facility. And these are like, oh. So you will get the receiving facility, the facility receipt manifest. You just go in and click it. Of course, this is one that's empty. But you're going to go ahead and go in and complete it and just mark, did you receive it intact? Was it missing or broken? Okay, it's very important because if something's missing or it's received broken, we need to know that so we can address that issue right away so it doesn't continue to happen. Okay, and then you just mark all of those. Hit continue, which will take you back to the second page, which is the date that you received the shipment, and then just mark complete receiving. And then you can send the slides back to the pathology department. Okay. Okay. And that is doing everything in link. Any questions? So next steps. And if you guys have any questions as you're doing this, please reach out. More than happy to help you walk through it. So the PCC lead coordinator for your PCC should send you out a list of outstanding cases that need to be sent to the DPR. Some may already have. When they scan slides, do we separate them by subject? Sorry, an email or a chat question. Yes. So when you pull the manifest to help you put everything into the box, because the order they are in the box needs to match what's in the manifest. So you want to make sure those are generally grouped by subject, and then they're numerical within that subject.
And also,
yep.
Also the slide copy uploads should be by patient.
Yes.
So that thing where you put the slides down on the photocopier, that should also be by patient, because that actually goes into HaloLink and is associated with the patient, so the pathologist can look at it. So it's cleaner, less confusing. I don't have to make multiple copies if it's once per patient. Thanks.
Okay. Oh, that's what you were asking about, the scan slide. Okay, yeah.
And make sure that you fill one for each patient, because what happened, I think that was said already, that AMHL receive a certain number of cases, but only some are recorded, or vice versa. That creates a lot of delays because they have to stop because they don't know what to do. So the paperwork has to match the slides.
Yes.
And the cases.
Yep, and that's why you want to make sure you have the right amount and the right participants in there. Same with when you do biosample shipping. The manifest must match what's in the shipment.
Yeah.
Okay, so if once you get your list from your PCC lead coordinator, you'll want to request the pathology materials. Again, if the slides are not available, please complete question 1 on the pathology slide collection form is no. Again, this lets us know that not to expect them. And again, MHL can send and receive international shipments, so you don't have to ship them to your PCC, then they ship and then back to you. Yeah, much easier now. But just make sure that you include any required documents, labels, stickers in the shipment to MHL, the return label, so it doesn't get stuck in customs. It's always best to ship Monday through Wednesday, as there are any folks there on the weekend. And MHL does observe the standard federal holidays. We're also going to have weekly office hours on Tuesdays from 2 to 3 p.m. or 2:30 p.m. This is in conjunction with Neptune. So I will be sending that invite out as soon as when we're done with this call. We just want you to come and join us for if you have any questions or running into any issues, or even if you have some tips that you want to share with everybody else. It's just a time for you guys to just really get all of your questions answered at this time, okay? I'm also going to be sending out a survey, and the survey has questions regarding, like, have you requested your labels? What are they? How many are you able to receive? How many are at your site? How many are off-site? And questions like that, just so we have a good understanding of like where you're at. Now, if you come to the weekly meeting and give us any updates that you have, perfect. If you're not able to make it to the meeting, but you do have updates, you can just go ahead and complete the survey again. Just keep the link, hold on to it, and then you can just check it out.
They're asking differences to Neptune, CureGN.
Yeah, so for the most part, no, there isn't any difference. The main difference I want to say between Neptune and CureGN is the DPR uploading and everything is all within GN Link. For Neptune, they actually have a separate DPR program that you upload everything in. But yeah, for the most part, everything is the same. The identification, making sure everything matches in the box is in the manifest is all the same.
One thing that I would like to stress is that we need to do a lot of cases in the next few months, and so you just jump on it. Don't wait until the very end, because there are always things that don't work the way you think they would, especially because you have to rely on pathology departments. So you make the request today, you get the slides in a month, and maybe they don't match, and maybe they're incomplete, and so on. So you got all the information, you got the training. Do it now and get it off your desk. It's good for the DPR, but it's also good for you instead of waiting March.
Yep, definitely. So on Basecamp, from the homepage, there's the study coordinators all folder. If you don't have access to this, please reach out to CureGN project management at U of M, and we'll get you access. But in here, there is under docs and files, the DPR training October 2023. And in here, you will find a copy of the slides, the manual of procedures for the DPR, as well as the different appendices. So we do have the request form that you can complete to request the slides from the pathology department. And there's also actually even on here now is a place for the PI to sign off on this as well. Sometimes it's easier to get responses if your PI signs on it. We have the DPR shipping through FedEx, a checklist for you guys to go through and just make sure that you have everything's done correctly before you upload it. This is very similar to the checklist that Jess uses. Hers is a little bit more in depth, but as long as you follow what's on here, you should be good. And then we have that flow chart of the DPR process. And then we also still have this DPR map. It's for quality control at your level or the site level. Okay, and it just shows you like some issues that you may run into, like dirty slides, pen markings, cracks, air bubbles. And then it also, let me download this. Okay. It shows you all that and basically what we want, what we don't want with those items to look for when doing your QC. And it talks about the labels. You want to make sure that the label is on there squarely and it's not in the frosted section. Unlike this one over on this example, we don't want it hanging over the edge or anything like that. This would cause an issue at MHL. So they would have to manually do the scanning, which costs a lot more money. So we definitely don't want that. No overhangs. We don't want it to be crooked and none of the original labels showing. And then we have a list of the different slides similar to the list that Laura had gone over in the presentation. But this, we actually gave you some other possible names of the stains, as well as some examples of what the slides will look like. So you'll know. On the computer, on this, it's a little bit hard to see, but there is like a little cover for the EM image. And then there's also some examples of what we don't want, you know, if it's a blank, if it's a control, and then the different like IgG, IgA, and such. Okay. So definitely use this when you're trying to figure out what slides to use. Okay. Like I said, this is all available on SharePoint, or not SharePoint, sorry, Basecamp. Okay. And if you don't have access to the study coordinators, please let us know and we'll get you access. Okay. Any questions?
Can I have two things?
Yes.
Sorry.
No, please.
One is you'll see in the survey when you get it that we are asking questions about like if all the slides are not at your facility and you've had to go to outside facilities, to give us some details, because we can then work on, you know, putting, oh, we've got 5 sites that have all requested slides from ABC, you know, we can get involved and call them and see what we can do to help. Relatedly, the second thing is if you're having challenges with your own pathology department, Laura B is very good at talking to pathology departments. So don't be afraid, you know, give it your best shot. But then if you're not getting anything, please let us know, because then we can try and help. And we are going to also, third thing, sorry, we're also going to be letting all the PIs know at the upcoming steering committee call. I mean, they know this, but we're telling them again that we're restarting this effort and asking for their support and help in, again, with their with the pathology departments as well. So we're also bringing that up. But again, if there's anything you think would make this easier for you, please let us know, and then we'll do our best.
Kelly, yeah, those are great tips and information. Any other questions? And I also wanted to say too, we definitely would like you to join the office hours while you're doing this, so that, you know, if you have any questions, but when you are getting your shipment ready, you can contact me and I will be happy to have a call with you. So you can actually like show me your slides and say like, wait, did these look like they're right in there? You know, just kind of helping you, making sure everything's right before you ship it in. So please feel free to reach out to me. I can always make myself available for you. Great. Well, we are at 12:30. Thank you guys. I really appreciate you coming, and look very excited to see